Hello, everyone. I'm Giulia Brunello from University of Düsseldorf, Germany. And welcome everyone to this Oral Regeneration Topic interview. Today we have the great pleasure to have with us Professor Hom-Lay Wang from University of Michigan, Professor in Periodontics. And we have the great opportunity to speak about a topic that I really am keen on. This is the third working group consensus conference report about the first GCCG that took place exactly 1 year ago in Boston. So this is a great opportunity for me to interview Hom-Lay, and I really want to thank you also the Osteology Foundation for this chance. So Hom-Lay, it's up to you to get starting to this topic. I think we have to clarify a little bit why the Edentulous Maxilla, why you started having this huge project and how everything started. And then we can dive into the consensus conference working group 3 report.
So good to see you, Julia. It's always nice, and I always enjoy your energy and your delighted personality, which is always nice, and especially being interviewed by you, it's an honor too. So for the GCCG, it's kind of reminded me about 3 years ago when I attended a consensus conference. At the time, Ronnie Yoon was there, and I was there. And he is the president of the EAO. I'm the president of the AO. So we kind of chit-chat a little bit because every one of us attend so many consensus conference. And over the years, I've probably attended the majority of the AAP consensus and also many global consensus. Same way with Ronnie Yoon on ITI, on the EAP, EAO. But it's geographically, to me, it's European, US, and it's we call the researcher or the people who publish the most and the people who represent the evidence, put it that way. However, there's no consensus among the cross-discipline, which means not just the perio or oral surgeon, but we have even the general dentist, prosthodontics, oral maxillofacial surgery, or even patient or stakeholder who manufacture the implant, who does the things for us, who innovative and produce a product. But most importantly, it's represented two big continental. But how about in Asia? How about South America? So there's nothing, it's not global voice, it's regional voice. And as a joke I had, at one time I asked one of my colleagues, I said, did you ever get a chance to read that EAO consensus? You know what response he had? He said, what? I said, EAO consensus. They spend so much time and publish the consensus. And then he just looked at me saying, that's European. So for me, that's
so
not.
already it was like not interesting for American audience because it was a European, and maybe it's vice versa because also from our point of view, sometimes like we think, okay, that's American, it's across the ocean, and we don't think really globally. That's true. This could happen also in Europe.
So that's the first things is that, and Ronnie and I say we can put all the resources together. We invite everybody. So basically, we're going to invite people from Asia, from South America, the Brazil, Mexico, the Japan, China, Korea, India, and the US and European and Australia. Everybody come together. And also the people represent every cross the specialty and also cross the manufacturer and as well as the patient's feedback. So the GCCG is based upon the patient's perception. So we develop a list. And so we bring together, and together with Ronnie Yoon, 3 of us, we sit down and we came out with it with the support from the ITI and osteology. I think we actually make it happen, and everybody get it together, put effort, and certainly with the support from EAO too. So the first GCCG is focused on the maxillary edentulous rehabilitation. Why is that?
Yeah, why this topic? Because I know a little bit the background, but I think it's interesting for the people that are hearing us. Why did you select this particular topic?
Because this is probably most things affect the patient's quality of life. the impact on the patient's function, aesthetic, speech, masticatory functions. And there are many things we don't know. People wanted to know, when can I do it? What should I do it? How many implants do I need? What kind of prosthesis should I have it? And what kind of a discomfort I may encounter? How much is it going to cost me? How do I maintain it? There are many things people don't know, and they just sit there and they trust in to the dentist, the specialist, or the people who provide care. But seldom we, as the dentist, do we ever think about what patient feel? Do we ever think about how do they perceive the overall treatment effect? So the
Sometimes
GCG,
it's not our opinion because sometimes we are super happy about the results and the patient is not really happy because maybe it was 1,000 of times at our office.
you got it. That's what we have a disconnect. So we starting to focus on the patients. For example, the one things I actually like the GCG, the first one is on the patient selection. We actually ask the patient, what did you happy with your current prosthesis or not? If you have a complete denture or remove partial denture, are you happy with it? If you are happy, there's no need for implant. If you want to improve, yes, we can add some implant to help to rebuild and give you a better function, better aesthetic. But if a patient is happy with whatever they have, why should we take all the teeth out or even change the prosthesis and to bring a new one, which may not be patient wanted?
This is actually something I was finding extremely interesting in the consensus report, like the big one, the one that it's including and summarizing all the different part of the consensus is like that we also say to the clinicians that if the patient is happy and there's no real necessity to proceed with the implant supported rehabilitation, maybe the rehabilitation that the patient is having is just enough. And I think this is quite unique for an implant-related consensus conference.
You got it.
So
You got it.
something that I like, and I think that could be something interesting for the how you develop a little bit the path of the patient coming to your practice, because we divided the consensus conference in 4 different main topics. Today we will focus on one of these 4 topics. But what I feel like it's interesting that all these topics are like thinking about the patient entering your practice through the patient selection to the maintenance, because it's a path. It's not just like one surgeries, because sometimes especially surgeons think, okay, I will see this patient today, maybe 2 or 3 more times, but then it's over. But actually it's not over. We have to think about the patient as a continuum in our practice.
So I think this is basically what is unique of a GCCG. We're starting from the patient selection to the way we diagnose, what kind of tool we use for the diagnose. Then we come up with a treatment planning and certainly treatment procedure. And we then talk about what kind of complication, how do we manage it. But then most importantly, we also talk about patient, about how to maintain it, because nobody talk about how to maintain it too. So with that, I think together we came out with a 4 working group. Try to answer the questions such as how many implants do we need? 4 or 6 or even more or less. And when do we do it? And can we do it immediate loading or not? And the other things is that, can I use in shoulder implant? Or can I use in pterygoid implant, or even we call the zygomatic implant? We didn't talk about pterygoid implant that much, but I think in the future people talk about it.
It's an option.
It's an option. And do we need to have a sinus grafting? And do we need alveolar ridge augmentation? And what's kind of consequence there? Then the last is, can we have implant supported prosthesis or remove all conventional prosthesis? So that's where the GCCG. So we actually came out with a 49 recommendation based upon 34 outcome assessment set, which is unique. And that's including about almost 20 of the patient-reported outcomes, and the other 34, which is 22 of the subjective and 2 objective of the we call the clinician report outcomes. So that's
for the whoever is like a hearing us, it's just like that we split it into prompts, so like a patient reporting outcome measure or not. And between the clinician reported outcomes, we were like dividing between like the subjective, that could be our perception of a result,
You got it.
and the objective, that is what you are used to, that is just like implant success, probing, and so on. It's just to clarify and to give like
So the
a
people
name
understand
to
a
this.
little bit. Yeah.
Yes, all these
Yeah, I
outcomes.
know you spend so much time in doing it, and we went through a lot of a Delphi survey. So actually, people didn't know we have expert survey, and we have a patient survey, we have a stakeholder survey, and then we have a finally consensus discussion in Boston. So every one of us divided into 4 groups, and we discuss, and we vote, and we argue. So that's how the things will be. And I specifically like it is we are selecting the individual who participate in this consensus conference, not based upon their publication, but based upon their clinical expertise also. So we have a people who are clinician, who knows what they do in their private practice, not the people who are publishing the paper, sits on the room and doing the research. But that's where we needed to hear more voice, not just the voice from like you or me, an academician, and you can hear from people who are in the trench mouth and do the treatment every day.
Yeah,
So
and
that's
also
what
there
I
were
enjoy.
like people from different like specialty, because I remember there were a prosthodontist, as you were mentioning before, like it was not just oral surgeon or periodontist, like it was a little bit more mixed group. There were a few maxillofacial surgeons as well, so I think it was quite a variegated group. You were in
I
group
know.
3. I was not inside the discussion, and then at the end I will ask you if there's something memorable that you didn't, that you will never forget. But in group 3, you were discussing the topic of bone augmentation. I was not spending those 2 days in Boston with you, because we were just meeting at the plenary session when everyone has to meet. But the discussion had already been filtered. So you came to the plenary already with the different recommendation they were actually afterward voted, and 4 other recommendations are coming from your group, and they belong to different phases of the treatment. So I think we can follow this path, and we can start with the first recommendation, if you are happy with this. And the first recommendation is related to the diagnostic, what we should do at the beginning when you already selected the patient. We think, okay, this patient needs an implant supported rehabilitation of the upper jaw. What should we do?
So I think this is the first recommendation is actually diagnostic. So for us, for the patient who has a fully edentulous area and we needed to undergoing the implant rehabilitations, we always suggest and recommend the 3-dimensional image, which is CBCT or medical CT, should be used routinely. We didn't make so strong, but we are highly recommended that should use them for routinely for preoperative evaluation and the digital planning. And this actually allow us, the clinician, to actually assess the volume, the recognition of any kind of anatomical constraints, or even prosthetic-driven implant position, so we can better plan our implant position. So we can understand if a patient can house the implant here or there, if a patient needs the standardized implant with sinus augmentation, or even shoulder implant, or if we don't have enough bone, we may want to use an zygomatic implant. So that's actually, we actually trying to help people to actually make the assumption and make the treatment planning before they even initiate the treatment.
Was there any kind of discussion about this topic, or that everyone were more or less aligned? Because we were from different geographical areas, and I think the perception of the risk related to dosages and so on could be a little bit different country by country. Regulations could be a little bit different. But what was the overall perception and the overall idea of the group?
I think the overall everybody agree we should have it, but there are certainly the issue related to the certain countries. They may not have a financial resource to have all the CBCT in every office. So, and they can have a CBCT in the centers. So that can be an issue. So we are using the term encourage, even though everybody was in a consensus saying we should have it. But you have to think about there are certain countries that they may not have the financial resource to buy all the CBCT and house in every single clinic. So you needed to think about maybe they're using the CBCT center, and the CBCT they use may not be most updated or most innovative machine which they can afford.
Okay, that's nice. I was part of the discussion during the plenary. I think this is quite important to say that this could be like considered somehow the ideal way, like to combine the CBCT or CT low dose preferable with the prosthetic plan from the beginning. So this could like be the best starting point. This is like the ideal way to reconstruct the edentulous maxilla, especially if you want to deal with big bone augmentations or like the edentulous maxilla. We have to think that most of the times we don't have a lot of bone, and also we could have like some complications with a decision of which kind of prosthesis could better fit my patient and which prosthesis could be affordable for my patient.
Yeah, so with this type of recommendation, we can help the local authority or the government to actually invest, to actually upgrade their dental office in the sense which I think it's going to make an impact because they understand this is the tool they needed to use in order to make a better judgment and better treatment approach and better serve for their population.
Yes, and it's not just like in US or Europe, it's worldwide.
So, you got it.
I like this approach. We can move to the second recommendation, which is related to the core of your group, which is hard tissue augmentation. I think that a lot of discussion was about hard tissue augmentation. So we have different kind of techniques, biomaterials, and so on. Can you give some insight into this recommendation related to hard tissue augmentation?
So let me first read the hard tissue augmentation, which is our recommendation too. It's basically we said it for vertical ridge augmentation in the edentulous maxilla. Barrier membrane should be securely fixed, either using tacks, pins, sutures, or screws to maintain space and limit micromotion, thereby improving the breathability and reducing exposure risk. And the funny thing is they actually cited one of my paper, which is the past principle, which talks about the primary wound coverage space stability, which is the key on the stability in here. So this actually discussed a lot, and people always in general agree in the non-resorbable membrane, which is like a PTFE or titanium mesh or titanium framework. Yes, you need a fix for sure. There's no doubt about it. But when we discuss the absorbable collagen membrane or absorbable membrane, then there's a little bit of discussion in between because some people are saying, it's a 1 to 2 teeth or 2 to 3 teeth. I can do without suturing, with suturing, or without tack. And their study actually published saying that if you fix or tack the absorbable collagen membrane, the benefit for you compared to without on the short limited area, it's only 0 to 1 millimeter on the crestal portion. So really that may not be big time, but majority of us, the clinician wise, if we can fix it, we prefer fix it because that gives you the stability of the wound. And that gives you a better outcome and less exposure rate, which is the truth. And so that's why the recommendation is that way. And we didn't limit it to the technique or the using to fix the membrane. We can use in tack, we can use pins, we can use suture. As long as you fix it, we accept that. However, I think that this is also a discussion in terms of in depth. It's a difference between horizontal and vertical.
That was
majority of the vertical.
It's quite more challenging. It could be like a.
Yeah, you got it because we know the vertical is more challenging. The space making becomes it's more important and maintenance. So to us, vertical, there's no doubt about it. Everybody agree. You got to fix it. You got to tax it. Nobody has any doubt. For horizontal, as I mentioned to you, there are people discussing, I do it, I don't do it. So, but in general, everybody say, if you have a chance to do it, do it. That's all. But
And
the
we are
the
not speaking
truly
about
effect,
like 1 millimeter of adhesions at the neck of an implant, of a single implant. We are speaking about the edentulous maxilla, where sometimes we really have a huge amount of bone to reconstruct.
you
So
got it. If you're looking for the fully edentulous, then yes. But again, this is also in terms of, I think it's a group one talked about it. If you have an anterior has an adequate bone, posterior you don't, but you only need to do the posterior. And see, that's a different. And then if you have a posterior have adequate bone, anterior deficient, then you need to fix it. So it's a little bit different. It really varies. And that's why I encourage everybody to get a chance to read all this paper. It's a lot of insight you can learn. You can enjoy it. You know, I read it as the novel. I just like it to read it, the things
I
and have
was
fun.
reading all, like actually, and I was enjoying reading all. It's a lot, but I think then some people then can focus on the topic they like most. So there's like this first summary that is helping you guiding through all the other papers, and will like someone can also focus. But of course, they have to focus on this one we are talking about today. I hope that it's going to be interesting for the people that are following this interview. And okay, we have went hard tissue. What about soft tissue? Because there could be a big discussion about soft tissues because
You know,
what's happening with the soft tissue?
more and more people recognize the importance of the soft tissue or the soft tissue phenotype. So the group three actually came out with the recommendation on the soft tissue, which, for me, I think it's always nice to read it instead of trying to give you my interpretation on the recommendation. So I'm going to read it for the audience. Basically, we said in patient with insufficient keratinized mucosa, soft tissue augmentation should be performed at implant placement or at stage 2 to improve peri-implant health and facilitate oral hygiene. So what do we try to say and we discuss is because people starting to looking into the maxillary edentures, and if you don't have adequate keratinized tissue or the tissue thickness, the patient cannot clean that area well because they feel discomfort, it hurts. So in order to maintain that, you need to have the thickness of the tissue and the zone of keratinized tissue. And I remember we had talked about the paper we published, our group published. We actually said you need to have the keratinized mucosa more than 2 millimeter, and you have a thickness more than 1.46. Basically, it's a 1.5. If you really want to cut it down, it's a 1.5, 1.46. If you have both, we can actually maintain the implant health better in the longer term. And also, I think Rakuto shows the paper on the longitudinal trial. The patient has a zone of keratinized tissue, can maintain the implant much better than the patient without keratinized mucosa width. So basically, we actually recommend it. If you don't have it, it's highly recommended you do it at the time of the surgery or at a stage 2 to make sure that the patient had the ability to maintain and to clean.
Not to have to augment as a consequence of a complication, because this could also happen, but was not part of the recommendation. But because sometimes it happens that we do a little bit too late when we already have complication to try to save our work as a very last option to maintain in maybe after years of the final delivery of the prosthesis, and we realize that the situation is changing. We might have some problems with the mucosa, and then we do an augmentation just like to save our work at the very end. So
Go ahead.
No, it's like this is also happening. I think sometimes we just avoid to do another augmentation just because we somehow deny that there's a problem, but sometimes there's a real problem and the patient is not really able to clean nicely after years of rehabilitation in the mouth.
So that's actually the trend in not just fully the upper edentures area. I think the trend of the topic is actually we try to always do in the prevention because I always believe prevention is better than the therapy. I do treat a lot of peri-implantitis or even peri-implant mucositis, and the free mucosa graft is one of my tools because that's where help the patient to clean and maintain and bring back to the disease resolution stage. So I do a lot of free mucosa graft. And that's actually kind of interesting because the recent article actually said some things which is unique to many of us. They said implant does not have a PDL, periodontal ligament. So if you do a bilaminar technique, there's no capacity to transform that area to the keratinized mucosa width. So the best one is still a free mucosa graft. So it's no longer by lamina you do a free connective tissue graft because you need keratinized mucosa, unless you believe in the tissue thickness. That's a different story. But
This is a
personally, I
different
like a
story. It
keratinized
was
mucosa
not
with.
touched by the consensus group, and maybe for a future consensus could be quite a crucial topic for discussion. I think it could be
Yeah,
interesting
that's a
to see.
management of periimplantitis. That's actually a different topic. That's what I say. It's off the topic.
But we still could have complications, not periplantitis. We're not treated by this group, but other kind of complications that are complications related to sinus lifting. So another recommendation from your group was related to complications, and in particular, what's happening in case of sinus lifting.
So the same things I'm going to read the recommendation. So most of you understand what it is recommended for management of intraoperative complication, in particular for sinus membrane perforation. So if a Schneiderlin membrane perforation less than equal to 10 millimeter occurs during the sinus augmentation, the perforation can be covered with a resorbable collagen membrane and augmentation can proceed. The tears less than 5 millimeter, strong recommendation to continue. Tear 5 to 10 millimeter suggests continuation with careful technique. Larger tears, which is more than 10 millimeter, require staging or aborting the procedure. So this is the things most people do in the fully edentulous area. They was talking about sinus elevation, either through the crustal or through a lateral window. So you're gonna encounter the perforation, which is some percentage range from depends on the paper you read. It range from 16 to 30%. So in that sense, if the perforation is less than 5 millimeter, we all try to manage it with absorbable collagen membrane. And some people even
It's
talk
a
about
green light. It's like you can
go for it.
proceed somehow.
You got it.
Go for
5 to
it.
10, people discussed about it. Some people say, it's not safe. Some people say you should go for it, but with caution. So the recommendation actually said 5 to 10, you can repair it and then proceed with caution. So it's okay.
I think also
But
the compliance of the patient could be taken into consideration because we all have the crazy diver that wants to go diving the day after, and we also have to deal with like good information of the patient in case of perforation of membrane. I think the postoperative time is quite crucial. Also, how the patient is behaving.
you got it. Usually the patient will be informed about actually from the up to 6 weeks, no flying and no diving and no excessive exercises to minimize any sinus movement. So the last one is actually when you're more than 10 millimeter. I think the consensus is people say prefer you wait to do a staging and aborting the procedure. But I do know couple oral surgeon will go forward with the fixation of a membrane, even in the sinus cavity. But again, the consensus on the group is probably the most conservative way, is try to stage it. So that's basically a recommendation from the group
Up to
3.
5 green light, a little bit of attention between the 5 and 10 millimeters. And for major perforations, most of the times you have just like to interrupt and re-enter in a second moment and do a stage surgery. So I like these recommendations, but I know that you also worked a lot on future possible questions. So in this paper that I invite all of you to read, it's about the group free from the GCCG, the report of this group free. There are also some ideas for future studies. All of you can start a new study. Of course, it would be nice to see the results soon, but for some of these, we need to wait a little bit of time also because we need a little bit long-term results and not just short-term results. What was one of the topics you would love to see as new evidence, something that you would like with your group, or you would like to read in a paper in the next years? Because you were like posing some good question about possible future topics that you should investigate, randomized clinical trials, perspective studies, and so on.
The most debated issue and kind of funny is, do we need a probe or not on the implants? That's very interesting, especially on the fully edentulous maxillary rehabilitation with the prosthesis like that way. How reliable of the probe will be. And should we remove the prosthesis and clean and probe and assess the disease activity? I don't think anybody has any answer. We're trying to use in whatever probe we have, but we know it's inaccurate. You have the angulation, you have the oval contour, you have a limited access, you have a patient discomfort. So many factors impact on the accuracy of the probe. And I think there's one thing is that the prosthodontics also do not like to annually remove the prosthesis and check the probing pocket depth or health status. So I think there's a way we should balance between removing the prosthesis. When should we remove it to assess the disease activity? I think besides just looking into the X-ray, because one of the concern to me important is we missed early detection of the bone loss, and that will leading toward to future peri-implantitis or peri-implantitis marginal bone loss. So we can do it preventively. That would be better. But without the proper tool, how can we do it? Without a proper access, how can we do it? So that's one thing I will probably encourage people to look into it, the probing accuracy. How do we probe? When do we remove the prosthesis to assess the disease status? So I think nobody has the answer. I know the American College of Prosthodontics just recommended they don't want you to remove the prosthesis annually, which is surprising.
There's also a problem that many clinicians are removing and screwing the screws every time, and maybe they never change also the screw. This is something that we have to take into consideration. So how much like our mechanical components can afford like this screwing and unscrewing. This is also something that I love the topic. Actually, I would love to see more strict indications, like some evidence related to this. This is a topic I do like. And I was hoping you were replying about a topic like this, because I think it's somehow controversial because we don't have a strong evidence for when should we remove the prosthesis. Like this is at which time point, when we already have a problem yearly, every 6 months, or when? That's something.
So that's the open question. People don't know. And the other question I had, it's very interesting. I know we are in the fully edentulous rehabilitation, and now one of the things we said the ideal implant or minimal implant for reconstructive the upper edentulous area is 4 up to 6 implants, and you can have OM4 and OM4 plus. I know there are many papers talk about the straight implant with a short implant or the curved implant on the long one. Tilted one implant. A majority of them are kind of in favor, but if that's in favor, why do we have so many complications on this type of rehabilitation? Why do we need a zygomatic implant, pterygoid implant, now even the guided subperiosteal implant? Why do we need that? What's the concern? And these are the things I would like to really dive into, looking at the pros and cons of this type of prosthesis. What things we are missing, and what is unique of these things? How do people should reconstruct this type of prosthesis to provide a patient a long-term stability? And I know, my personal experience, I have several patients struggle from it, but I know people say it's okay. But again, if it's okay, then we shouldn't do the zygomatic implant or pterygoid implant, or now even the guided subperiosteal implant. That means we have some things we miss it. I don't know what we miss it, but I would like to.
So you would like to have more evidence related to this categories.
I would like to see more control evidence and more a neutral study and prove one way or the other. Because I like the concept, but I also concerned about what has happened and what has changed in the perception on the patient.
That's suggestive for all of the ones that are hearing that could like start new study on these topics. And just before ending, I like gossip. I'm Italian. I like a little bit. Do you have something like a curiosity, something funny that happened in your group, or like something memorable that you remember from Boston? Nice discussion, not polemics, huh? Something like that. It's nice to share.
The discussion is always interesting. People express their opinion, their experience, and eventually the people say, "Oh, I like your idea. I like your approach." So you see the people who are initially very resist to hear other opinion. And now when you present the evidence, when you present the pros and cons, they say, "Oh, I never thought about it." So that's what you bring the people together. You hear the other side of the information, not just what you believe. We all sit in our ivory tower and believe what we do is right. What we said is correct. But how often we need to open our ear to listen from other people's point of view? I think the consensus is bring the people from different voice, not only a clinician, not only individual, but also patient, now even stakeholder, bring their idea, bring their feeling, so you can hear their side of the story. The more you can hear other people's sides of the story, the better you can make a good decision, good recommendation for the public and also for our profession.
That's very nice. And what I was having the feeling that during these 2-3 days in Boston, they were not enough because the discussion was so animated. It was like so interesting. We really went through so many recommendations, and the discussion was really bringing some new topics every time related to the topic we were discussing. So it was really nice, challenging to stay on time, and also somehow I was thinking about the perspective of different people from different nationality. In my group, we were discussing a little bit more, as in yours, about CBCT and CT, like different perspective related to geographical differences. And that was really enriching because sometimes we, as you say, we are like in our tower, we don't see the point of view, not only of the patients, but also the clinicians from another side of the world. And this is somehow absurd.
Yep, so, you got it.
From my point of view, we are going to the end. I want to thank you, Hom-Lay, that you will have the last word and say, I hope you are encouraging everyone to read the paper of the GCCG. And I want to thank you because, as always, you are like a very precise and you give a very nice replies with supported by evidence, by your knowledge. And I really want to thank you for your availability. I think everyone will enjoy your perspective, and not only your perspective, the information that are coming directly from the paper of the GCCG.
Yeah, I think my last word is, information is out there in a public domain, and it's us who needs to digest. So we needed to find the time to read it, to digest it, because we put so much effort into generating this very incredible document. But we needed you to read it. We needed you to share with your patient, with your referral doctors, and even with your the company person, so they know what you are for. And I think that's the most important. Spend time, read it, digest it, and share. And so I wish you all the best.
They need a lot of time to read the whole volume, but let's start with the group 3 paper. And I would say hello, everyone. Hello and goodbye to everyone. And thank you, Hom-Lay, for the great time with you.
Thanks, Giulia. Thanks again. And good luck for everyone. Thank you. Bye-bye.